Okay, so good evening, everybody. Looks like we've got a fair number of people on the call tonight. Um, this is the AMSSM Fellows Online Education Lecture for the week, and it's my pleasure to introduce Jim Moeller, who's joining us here from West Virginia. He is a professor in the Department of Orthopedics and Sports Medicine at West Virginia University, where he serves as a team physician and is a member of the fellowship faculty. Jim and I have known each other for a number of years, working on committees together through AMSSM, but we actually got to work together last winter in January 2023 up in Lake Placid, New York, where he was helping cover the speed skating event. He's been working for USA Speed Skating since 1997. So long time, lots of experience, which is with a very exciting sport. If you've not watched that during the Olympics, then you definitely should. And if you ever get the chance to see it up close and personal, it is just even more exciting if you're there in person, the speed these athletes go around the rink. So we got to work together in Lake Placid, and he is a vastly experienced team physician. He's going to be talking to us about some of the things he's seen in the training room. He has over 30 sports medicine publications, he's edited a couple of textbooks, and I'm going to let him get going very shortly. Just a couple of seconds of housekeeping. Please mute your microphones, use the chat function to ask questions. We are very happy to answer those questions, but perhaps just voice them in the chat box to get started. And yeah, excited to hear what you've got to say, Jim. The floor is yours, my friend.
Thank you, Hamish. I appreciate it. And thank you, everyone, for joining us tonight. It's a lot of fun to see what's come from this fellow online lecture series that we started back quite a long time ago now. This is year 5, which is very exciting. We want to thank Andy Meyer, who's on the call, who's our AMSSM representative for this project. He's really the kind of the glue that keeps this together and keeps us all moving forward. So I was charged tonight with talking about high yield medical topics for the training room. So these are the things that we will commonly see in a training room setting. A lot of it is potentially review for you, depending on what your primary training is. But I just want to kind of drive home the point that you do see a lot of medical issues in the training room. It's not all orthopedic and musculoskeletal medicine. Sorry about that. I was trying to click onto a slide there. So again, I have nothing to disclose. We're going to talk about mostly objective 3 here, understanding the common problems, which you'll see in the training room. There's just one slide each on the first 2 objectives tonight, talking about some of the medical legal aspects and understanding your role within the training room. So let's just get to these. So some medical legal considerations. If you are performing services in a training room in a high school setting or with club teams and such, you have to consider that you may be treating minors, and that is a whole different animal, if you will, than treating collegiate athletes who are adults. When you are treating minors, you have to make sure that you have consent to treat the minor. You have to make sure that you have consent to treat the minor with a parent not being present potentially, if you're going to be doing it in a school training room situation. Which is one of the reasons for me personally that I don't like doing scheduled training rooms in a high school setting, because again, I have to have all of that documentation before I can see these people, and it's very difficult to do. You have to make sure that you're compliant with all of the HIPAA policies for patient privacy, and you also have to be careful about patient safety. You want to make sure that when you're evaluating patients in a training room setting, that your encounters with them are interruptible, that they're potentially observable. So in our situation at WVU, we have private physician offices, but we will leave the door open partly so people can get in if they need to. And we also make sure that from a safety standpoint, we always have another provider in the setting with us. it's typically going to be an athletic trainer that is in there with the student athlete and the physician, again, for a patient safety perspective. You have to make sure that you're documenting your visits in the training room as well. Again, another reason why I don't particularly like doing scheduled training rooms in the high school setting, because the documentation, pencil and paper is fine if that's how things are done. But in the day of electronic medical record, in order to do that, all of the student athletes at your school would have to be listed as patients within your record system so you could document them appropriately. Again, if you have all these things set up, I'm not saying that you can't or you shouldn't do training rooms in the high school, but it does add a layer of complexity. We'll talk about that a little bit more in a moment. And finally, malpractice coverage. You have to make sure that your malpractice coverage extends into the training room. I was in private practice for 20 years. And one of the things that I did with my my malpractice company, insurance company, was I convinced them that the training room was an extension of my office, as well as the field and field side, court side, rink side. All of those were extensions of my office, and so my medical malpractice covered me in all of those situations. In fact, at my university training room, we included the address of the training room onto my policy, so I would be covered there. And again, I was in private practice at the time, and it was not very difficult to do. Certainly, if you're employed by a system and this is part of your employment, the malpractice coverage should reach to that area for you. Understanding your role, there are different roles really when you look at the high school versus the collegiate training room. In the high school training room, the team physician is typically not going to be the PCP for the student athlete. It depends on the community. I saw Derek Olson on the call here today. Derek and I go way back. He was a resident in a program that I taught in, and he's been in practice now for a number of years. He is in a town up in northern Michigan, the Lower Peninsula, where he is one of the primary care physicians in the town, and he's also the high school team physician. And so a lot of his high school sport athletes are also his patients. And so he is the PCP for those folks. But in the high school setting, it's mostly focused on musculoskeletal care, and prescriptions for things like medications and testing is often recommended in those settings, but not often ordered, because again, you may not be the patient's primary care provider. You may not be on their insurances, and so the insurance won't necessarily accept your orders, and so on. So again, you have to consider these things when you look at your role in the high school setting. In the collegiate setting, the team physician is the PCP during the academic year, certainly. And so there's a wide range of things that you'll see, including musculoskeletal, general medical, and mental health issues. We're going to focus on the general medical issues tonight. And in this situation, testing and medication prescriptions, things like that, they're going to be ordered straight out of the training room. So let's get to the common problems that we're going to see. I have a little roadmap here, a variety of different common complaints that you might see. We're going to stay away from rash and skin problems, because it's my understanding that that is potentially going to be its own talk in future sessions of the online program. So what I'm going to do is I'm going to ask somebody. I'm going to put you guys all on the spot. So I thought I saw Joe Friedley on here. Joe, if you're on here, unmute your mic for a second and tell me which topic you want to talk about first.
Hey, good evening, Dr. Moeller. It's good to see you. We'll just start from the top. I'll go with cough.
All right, let's hit cough then. Thanks, Joe. Good to see you. I don't see you yet, but I will at the end. So let's talk about cough as a presenting complaint. And you may get a story something like this: an athlete who presents in late January with acute onset, minimally productive to non-productive cough with fever, chills, myalgia, headaches, rhinitis, some sore throat. On examination, they're ill appearing. They do have a fever that's measured orally. Their pulse ox is pretty good. They have some mild bronchi, but they're not in horrible distress, but they're ill appearing. So clearly, you're going to say, well, God, this has got to be influenza. And in 2019 and before, you had a pretty good shot at being right when you had fever, myalgias, a mild cough, and acute onset illness. But since then, obviously, everything has changed, and it could be COVID as well, because the presentations are going to be quite similar. That's one of the problems between these two things, is that the CDC has shown that there are a lot of similarities in the disease processes for influenza and for COVID, and the differences are fairly slim, quite honestly. One of the big differences is how long someone may be infectious for, and how long the symptoms may last. And in fact, if you look at the list of differences here published by the CDC in 2022, two of those things are actually the same thing. So again, it's very difficult to determine if it's flu or if it's COVID just based on the patient's presentation. Influenza is an acute respiratory infection. There are 4 types of influenza virus, but type C and type D are not associated with human infection. And when you look at types A and B, which are associated with human infection, type A makes up the majority of cases. Patients are going to present with a non to minimally productive cough, the symptoms that we were just talking about in the case. And back in 2005, there was a study in the Annals of Emergency Medicine that showed that if somebody came into the emergency department during flu season and they had a fever and a minimally productive cough, just those things alone, there was a positive likelihood ratio of 5.1 that the patient had influenza. The problem again is that the diagnostic accuracy of H&P alone is low, especially now that COVID has come onto the scene. There are rapid antigen tests that can be performed that are quite specific and have pretty good sensitivity. They can discern between influenza A and influenza B. It takes about 30 minutes to get these tests back. But again, you do a nasopharyngeal swab and you can get your answer if you need to go that far. And we'll talk about that in just a moment. These tests tend to be most accurate if they're obtained in the first 4 days of the symptoms complex. Treatment for most people is just going to be symptomatic. Thankfully, with most of our athletes, they're relatively young and relatively healthy people. And so just supporting them with rest and fluids and over-the-counter medications for symptom control is often enough. Now, if they have underlying medical conditions which put them at risk for having worse troubles from influenza, then certainly medications can be added, as you see here, but they're best added if added in the first 48 hours of the onset of symptoms. Interestingly, these medications don't really speed the recovery from influenza significantly. So they're fairly expensive for maybe a half day to a day gained with regards to the patient feeling better. But again, if someone has a history of bad asthma or other lung disease, if they have cystic fibrosis, which some of your athletes may, if they have heart disease, if they have some type of immunocompromised situation or they live with somebody who does, this may be something to consider. Prevention is key. There are trivalent and quadrivalent immunizations that can be performed. These are not live viruses, so you do not get flu from a flu shot. You can feel lousy for a couple of days, and people think that they got the flu from the shot, but they really don't. The CDC recommends that all patients over 6 months be immunized. And again, there are multiple formulations that can be used. The nasal spray is a live attenuated virus. It's only recommended for people between the ages of 2 and 49, but should be avoided in pregnant women, immunocompromised patients, and caregivers of such. And so we tend at WVU to use the shot, and we have team influenza vaccination days. Certainly the things that we learned during COVID with staying away from sick people and washing your hands a lot, and you saw the numbers of cases of influenza during that time drop substantially, and it's just sensible medicine. When people are sick, you want them to stay away from you, and you want to stay away from them, and you want to make sure that you're using good hygiene. Some considerations in the athlete is that intense exercise during the high flu season could increase someone's susceptibility to contracting influenza virus. At the same time, moderate exercise may reduce the risk of death from influenza infection. And so your athletes who are in the high training periods and intense training periods in that December to February type of time frame may be at a greater risk of developing influenza, contracting it at least, and then showing the clinical signs of it. Now, these studies were done on mice, and so you can argue that it doesn't necessarily correlate with human infection well, but again, these were pretty well done studies looking at exercise and influenza. Some other considerations in the athlete: you want to keep possibly flu-infected athletes away from other athletes. A lot of times when a patient calls in and talks to the trainer, I've talked to my trainers about this. If they call in and they have a fever and they have a mildly productive cough and they have some body aches, myalgias and things like that, I really don't want them coming into the training room if we can help it. If we can manage that and try to figure things out with them in their apartment or their dorm room, instead of bringing their infection or their potential infection into the training room and infecting other athletes and other teams, that would be great if we could. Certainly during that cold and flu season, we have masks at the door, and we have stations with hand sanitizers and things like that. And if they're ill, we ask them to put a mask on and wash their hands before they come in, because again, we want to expose as few people as possible. Remember that people with influenza are contagious from a day before they start to feel poorly to about a week after, and they're most contagious in the first 3 to 4 days of the illness. While they're febrile, they should not participate, and that's true regardless of the cause of fever. You can't regulate your body temperature as well when you're febrile because your thermostat's off. And so no athlete should be participating while febrile. And then you should try to make sure you're reducing the contact with their teammates while they're considered infectious. And then again, one of the big questions is, are team flu shots a good thing? And for your institution, it may be. That's something that you have to discuss with your medical team, your administration, and make a decision that seems to be best for you. When we talk about COVID, it's very similar. It's clinically indistinguishable from influenza. It's a different virus, obviously. But again, the diagnostic accuracy of history and physical alone is not very good. There is a rapid test for this as well. It's an antigen test as well. And again, the specificity is very high and the sensitivity is very good. There are home test kits now that can be used for COVID and influenza A and B, and test all of them at the same time. And so again, what we try to do if our athletes are calling and they're saying, hey, look, this is how I feel, and we're thinking this could be flu or it could be COVID, we're trying to get them a test kit so we can test them without bringing them in, because again, we just don't want to expose our athletes who are not sick to people who are. This slide is going to look very similar to the last one with regards to treatment. Again, if they don't have any other major medical problems, no cardiac or pulmonary conditions which put them at risk for serious disease or serious complications from COVID infection, you don't have to use medications, antiviral medications, but if you do, you can see the antiviral medications listed here. Again, this is best utilized if it's started early, but up to 5 days of onset as opposed to just the first 48 hours. Back to some considerations in the athlete. Once again, no participation while febrile. Can't say that enough. You want to keep possibly COVID-infected people away from others until their symptoms are resolving and they've been afebrile for at least 24 hours. And again, when they do come back, you want to take some precautions to try to reduce the exposure to their teammates and other athletes. So moving away from influenza and COVID, here's another athlete who presents with cough, again, a non-productive cough. They have nasal congestion, mild sore throat, so some more above the neck types of symptoms, some fatigue maybe, but no fever this time, no body aches or muscle aches. And on exam, they're afebrile with swollen turbinates, mild pharyngeal erythema, some postnasal drainage. Their lungs sound clear. In this situation, we're talking more about a viral URI. Compared to influenza, it's going to be a more gradual type of onset. The symptoms are generally less severe, not always. Usually it's no fever. Athletes will often say they have fever, but when you ask them, well, what did you measure it at? They've never measured their temperature. They feel like they have a fever. And it's hard to put a lot of weight into that. So make sure that you're able to measure their temperature in the training room. Muscle aches are unusual, and they have a lot more nasal and throat symptoms. So again, it fits with more of an upper respiratory, again, from the neck up type of illness, as opposed to more cough and muscular aches and fever, more systemic types of symptoms. The treatment, same slide as before, symptomatic. Some folks automatically put people on antibiotics. There's a reason not to do that, aside from trying to avoid selecting out bad bugs. But again, symptomatic care is usually enough. If we move on to the athlete with a cough, again, late January, I'm trying to make these all seem very similar. They do have fever, chills, dyspnea, pleuritic chest pain. They're ill appearing. They have a fever, maybe some megaphony, E to A changes. Athletes do get community acquired pneumonia. You have to be prepared for that. It tends to be more common in older adults, but it can happen in your athletes as well. If you're concerned about that, you do want to get a chest x-ray, and you can start empiric antibiotic treatment. One of the things to consider when you're talking about antibiotics in the athlete, fluoroquinolones are very popular for community-acquired pneumonia, not a good choice in the athletes. You know the risk for tendon rupture. There's also a risk for potential ventricular arrhythmias and cardiac arrest with fluoroquinolones. There's an interesting board question that if you're going to use a fluoroquinolone, that using a magnesium as a supplement while you're giving them the fluoroquinolone could reduce the risk of tendon rupture. So that was on a CAQ a couple of years back. Macrolides can also cause some cardiac issues and prolong the QT interval. So if you have somebody who has a family history or has a history of themselves of long QT syndrome, you want to avoid macrolides. Antibiotics in general have been linked to decreased athletic performance. And so again, if you don't have to use the antibiotics, you want to try to avoid it. And then recovery, full recovery and full ability to do cardiorespiratory exercise at the same level as before the illness can take quite some time. So you just have to be patient with these athletes as they're recovering. Don't forget there are other causes of cough in the athlete: exercise-induced bronchospasm, vocal cord dysfunction, exercise-induced laryngeal obstruction, GERD, allergies, and athletes smoke and athletes vape. And so this can all lead to cough, and so you have to consider all of the possibilities. So we'll jump back to the roadmap, and I think I saw Trevor Goal on here. I'm just going to pick on the people that I recognize their names. Trevor, jump in and pick a topic for me.
Yeah, I'll take fatigue for 200, please.
All right, let's go to fatigue then. I appreciate the Jeopardy homage. I actually have a whole Jeopardy set up on slides and do Jeopardy with different topics as well. Maybe we could do that someday. I actually have a buzzer system too that I use with the fellows when we do it in person. So fatigue, here's a 19-year-old female cross-country runner who presents with fatigue as a primary complaint, but has noticed decreased exercise tolerance, worsening run times, no injuries reported. She has 6 menstrual periods a year. She's alert and oriented, normal affect, ENT, heart, lungs are normal, and she has some slight conjunctival pallor. What I'm trying to draw you to, or trying to lead you to, is the thought of anemia in the athlete as a cause of fatigue. Iron deficiency anemia, B12 deficiency anemia, these are both not uncommon. There is something called sports anemia, which is kind of a misnomer. It's not truly an anemia, it's a false anemia, in which the hemoglobin and hematocrit and red blood cell volumes are lowered due to the dilutional effect of an increased plasma volume, which usually is going to occur in the first few days of intensive training. So it does not affect training or performance because the athlete's ability to carry oxygen is actually not changed. So you'll see sports anemia listed. Again, there may be questions about this on your CAQ, but it's not a true anemia, where iron deficiency and B12 certainly can lead to true anemias. And there are other causes too, but we're going to focus on these. So if you look at iron deficiency and anemia, 20 to 50% of female endurance athletes are considered to be iron deficient, where up to 17% of male endurance athletes are iron deficient, but not all people who are iron deficient are anemic. And so iron deficiency anemia in males is actually fairly rare, and it's up to 15% in female athletes. And again, what we're looking for is a microcytic anemia in this case. There are risk factors for developing iron deficiency and iron deficiency anemia. A vegetarian or vegan diet is a risk for it. Inflammation that causes increased hepcidin activity and decreased iron absorption is a risk. And then increased iron losses from menstruation, from sweat, heel strike hemolysis, that's common in runners, GI losses, and GU losses. If you think about distance running as an example, cecal slap syndrome, where the cecum, which is kind of free to move about a little bit, if slaps against the abdominal wall, you can start to get bleeding from that area, get GI losses that are not noticed. It doesn't really cause hematochezia or melena or noticeable blood in the stool, but there can be enough losses where iron deficiency can develop. Same with the bladder. It's not unusual. There are studies looking at ultra marathoners and marathoners, and the number who have hematuria upon completion of these races is quite high, but that hematuria should resolve within a few days of the race. But again, somebody who's doing training for those types of things can get some GU losses. Remember that vegetables contain non-heme iron, which doesn't absorb as easily as heme iron. So that's why there's an increased risk for iron deficiency in vegetarians and vegans. Hepcidin, just to remind you, it blocks iron absorption and iron transport. And elevation of hepcidin can be elevated in 1 to 6 hours after an intense workout. And again, that can lead to reduced iron absorption, which over time could lead to iron deficiency and then eventually to anemia. When you talk about B12 deficiency and anemia, low B12 has been associated with decreased performance of high intensity exercise, and that's not anemia. That's just people with low B12. And people with higher B12 levels have been associated with enhanced athletic performance, especially in females. And so again, even if you don't have anemia from your B12, it could affect your athletic performance. The prevalence of B12 deficiency anemia is widely varied, from anywhere from 1.5 to 15% in the population, and certainly more common in older age groups, but it can happen in our athletes as well. Looking at potential contributors, vegetables do not contain B12. And so again, people who are on a vegetarian or vegan diet are going to be at increased risk for B12 deficiency. And then people with reduced intrinsic factor absorb less B12 from the diet. Decreased absorption is a normal part of aging. People with disease such as celiac disease and Crohn's disease may have less absorption. And people who use proton pump inhibitors and abuse alcohol also will have reduced B12 absorption and could develop this macrocytic anemia. And again, anemia, certainly because of the reduced oxygen carrying capacity in the blood, can lead to fatigue as a common complaint in your athletes. So let's go back and look at a 19-year-old cross-country runner who presents with fatigue, same as before. Decreased exercise tolerance, worsening running times, all is the same as before, no injury, mild recent weight gain. They have 6 menstrual periods per year. They're alert and oriented, they have a normal affect, normal ENT, heart and lung exams, heart rate is 50 and regular. What I'm trying to make you think about in this situation potentially is, does the person have hypothyroidism? Hypothyroidism has a prevalence of approximately 5% in the general population, and subclinical hypothyroidism can be seen in as much as 8%. Thyroid disease is more common in women than in men, and that's pretty true across the board for thyroid disease. And it certainly is more common with increasing age, but it is something that you will run across in your athletes from time to time. When you look at the symptoms and signs of hypothyroidism, there are a number of these that can lead to problems for the athlete with regards to their ability to train and ability to perform the way they wish. Weight gain is a problem in monitored sports and aesthetic sports. So that can be an issue for our athletes, and carrying additional weight may affect their performance certainly as well. So we're talking about fatigue and weakness as our primary complaint here. So that comes into play as it can affect ability to train, and it can affect competitive performance. Heart rate can be slowed, as I was trying to show, although a heart rate of 50 may not be that unusual in a cross-country runner. I probably should have gone lower. But it's also more difficult for them to reach the normal maximum heart rate. So it may reduce their ability to train at the level that they wish in order to get the performances that they desire. And then there are also a number of musculoskeletal issues that can present as part of the hypothyroid complex. And so again, it's a common cause of fatigue that you'll see in the general population, but you can find it in your athletes as well. I do want to point out that there are other causes of fatigue that I'm just going to list here because in an hour we can't go through everything, but depression is something that has to come to mind, poor sleep hygiene, anxiety and stress, because these are not just athletes, these are student athletes. They're young adults, they have a lot on their plate, and their fatigue may be due to problems that are more of a mental health area, like depression and anxiety. Red, certainly, and then you have to consider pregnancy. It does happen that your athletes will get pregnant, and that can be the cause of fatigue. So you always have to consider that as on the differential in a female athlete. When you're working up fatigue, you certainly want to get a good history. You want to screen for depression, sleep quality. You want to do an excellent physical examination. And I'm sure you're all excellent clinicians. That's the goal of our training program, is to develop excellent clinicians. And so do a thorough physical exam, and then consider your diagnostic tests. CBC to look for anemia, whether it's microcytic hypochromic, macrocytic hyperchromic, normocytic, normochromic. It may drive you towards looking at very specific causes of anemia, thalassemia, and so on. Checking a ferritin. Patients with a ferritin of less than 30 micrograms per liter and a normal hemoglobin and hematocrit, you're probably going to want to treat with some iron supplementation. If they have chronic inflammatory disease, you may want to treat at serum ferritins that are even a little bit higher than that. Checking your B12 if they have a macrocytic anemia, and supplement with B12 if their serum B12 is less than 150 picograms per milliliter. Patients who have a little bit higher level of B12 in their system, and you're wondering, should I really supplement these people or not? You may want to check a methylmalonic acid level, because that level will increase as their exposure to low B12 in their system is more prolonged. And so if you have kind of that next stage up of B12, but they have an elevated MMA, you may wish to go ahead and start to supplement those folks as well. And then certainly a TSH is something that should be on your list of labs to consider if you're going to work these people up, to determine whether they're hypothyroid or hyperthyroid for that matter. A lot of folks will wait for a couple of weeks and just kind of follow the athlete and looking into other things first. But again, this should all be considered as part of your workup for fatigue.
Jim, before you move on there, what are your thoughts on asymptomatic screening with these same labs? I know some coaches basically want to test their entire team for ferritin, for instance.
Yeah, I'm torn, Hamish, because when you look at the recommendations regarding screening testing for athletes as part of the PPE and the PPE monograph, which we've been a big part of formulating, additional testing is not actually recommended, and that includes EKGs. When you look at the American College of Cardiology and some other organizations, and our cross-country track team at WVU, we only have a female cross-country track team. We do screen, because again, we find that anemia is a little more prominent in that particular sport, especially for the females in that sport, and so we do some screening. We're very quick to approve screening if it's requested by the athlete, and or if we have symptomatic presentations to the training room. We don't screen every sport though, and we don't screen males and females equally. Who wants to pick the next topic for us? Anybody jump in and tell me what you want to talk about next. Don't be shy. Step right up.
Let's do eye issues.
Eye issues. All right. I've got a great slide at the end of the eye issues. I'm glad somebody picked that one. Who said that?
That was me, Joe Friedley.
Joe Friedley again. All right, Joe. Joe is one of my fellows. So Joe, I only got to spend half a year with Joe. I moved to West Virginia halfway through his year. But Joe and I go back a long way. So let's talk about eye issues here. You have to consider the anatomy of the eye, posterior chamber, the lens, the anterior chamber, the cornea, the lids, all these different things. And so if we look at the cornea specifically, there are a number of different layers to the cornea. The epithelial layer is about 50 microns thick. It's about 5 to 7 cell layers thick. Injury to cells in the epithelium will usually regenerate within about 7 days, and it assists with the blockage of dust and into the eye. It's a nice area too for the water barrier to help protect. It absorbs oxygen and nutrients from tears. And again, it helps that tear film spread evenly across the eye. Bowman's layer is the next layer. It's much thinner, only about 8 to 14 microns. It's dense. It separates the epithelium from the stroma, and it protects the stroma from physical damage. But if you damage Bowman's layer, that could lead to permanent scarring. The stromal layer is the thickest layer. It's about 500 microns thick. It's collagen fibrils, which are arranged in bundles that are parallel to the corneal surface. It's avascular, should be perfectly clear, and it helps give shape to the cornea. It has a good elasticity and good strength. Now, I probably have always mispronounced Deschamets membrane. It looks French to me, so I try to, without having taken French, try to make it sound French. That is also a thin layer that sits between the stroma and the endothelium. And then the endothelium itself is a single layer thick. It's only about 5 microns thick, and maintains the fluid content of the cornea, acts as a pump to keep the stroma from filling with fluid. The cells here do not degenerate once they're destroyed. So if you have injury down to the endothelium, there'll be stromal edema and corneal opacification that occurs. Eye injuries, when you look at the epidemiology, in a study that was published in Sports Health in 2017, looking at high school and college athletes, or a slightly different period of time that they were studied. Most of the injuries of the eye took place in competition in the high school athlete, but you can see that the risk of injury to the eye was 0.68 per 100,000 athlete exposures. The risk for eye injury in the collegiate athlete was much higher. The relative risk was higher in competition, although most of the injuries took place in practice in the collegiate athlete. When you look at the mechanisms between high school and college age athletes, direct contact is going to be the number one in both. Contact with another player is about 50% in high school, almost 2/3 in college. And in men's basketball, it accounts for almost all of the injuries. Whereas in direct contact with a ball is going to be really high in baseball, obviously softball as well. And you can see that the diagnoses are very similar between high school and college, although the percentages are slightly different. From that same article, this is just a graph. It doesn't really come out terribly well, and I apologize for that, but it looks at the rate per 100,000 AEs for both high school and college, and you can see the overall rates. And I've kind of highlighted some of the sports that had the highest risk, rate ratios, with wrestling, field hockey, men's and women's basketball. Changes in rules and changes in equipment has led to reduced eye injuries in certain sports. Ice hockey, for example, in the high school age group and in the collegiate age group as well, you have to have full facial protection. And so eye injuries are very uncommon in ice hockey now, where in the old days when you could wear a half visor, or even when I was a kid, you didn't wear any facial protection. That explains a lot. It was a free-for-all with regards to lacerations, dental injuries, and eye injuries as well. So let's talk about a case. A 19-year-old, they're all 19-year-olds. Athlete presents to a training room with complaint of eye pain, increased tearing, light sensitivity, and a foreign body sensation after being poked in the eye while playing basketball. So getting poked in the eye, something getting in right in there and causing direct trauma. You're thinking about penetrating trauma. This usually comes from a stick, a racket, a sharp object, a fingernail. And on your differential for penetrating trauma, you have to think about foreign bodies, you have to think about corneal abrasions, and you have to think about globe injuries. So here's just a couple of penetrating injuries to the eye. These were not patients of mine. I took these off of the internet, but I thought they were pretty striking for a penetrating eye injury. we're going to just quickly go to blunt trauma, and then we'll get into some specifics here. So if the case is that they were hit by a ball, such as a softball to the eye, and you're thinking blunt trauma from a projectile like a ball or a puck, a fist or an elbow, your differential may be slightly different, thinking of orbital hematoma, orbital fractures, and hyphemas. I'm from Detroit originally. This is my team. This is my guy. Took a puck right to the eye. He was not wearing any facial protection. He started wearing it shortly thereafter. Remember, on your eye examination, you want to do general observation, look for swelling, hematoma, lacerations. You want to look for lid lag, a misshapen pupil, an obvious hyphema. You want to test their visual acuity and do a neural examination looking for pupillary light response, extraocular muscle use, and then facial sensation and muscle control. That all has to be part of your examination. So if we go back to the first penetrating trauma type of scenario, here is a slide that shows a foreign body. You can see that small metallic foreign body after you've averted the lid. If you find that, you want to remove that. It can cause corneal abrasion. And so you want to evaluate for foreign bodies when there's a penetrating trauma. You want to look for corneal abrasion with fluorescein stain and blue light examination. Sometimes it's difficult to do that in a training room setting. Oftentimes you may have to have an ophthalmologist do slit lamp examinations if you want to find very, very fine abrasions. You also want to look for the leak of aqueous humor, which would indicate obviously a deeper injury. So if you have a foreign body like this, as you blink, that foreign body rubs across the cornea over and over again. And so you may end up with a fluorescein stain picture like this. And you can imagine the tracking of that foreign body as it kind of slides around as person is blinking, how it makes multiple scratches, as opposed to a single traumatic injury like a fingernail to the eye, where you may see more of a gouge, a single injury to the cornea. And again, if it's in the epithelium and it doesn't get down into Bowman's layer, the likelihood is these will heal quite nicely. You do want to look for the leak of aqueous humor. This is Eric Seidel, who is famous for Seidel's sign. Unfortunately, my next slide, it was supposed to be a video. It didn't come out, but you can get a hint of kind of a fluid type of appearance here. Again, I apologize. The video was real nice. Blink and then the fluid would drop down, and blink and the fluid would drop down. That's a Seidel sign. That's showing that you're leaking aqueous humor. So you have a globe disruption in that situation. You need to get them to an ophthalmologist right away. For foreign bodies, you want to remove the foreign body. You want to control their pain with any means necessary. Most don't need topical anesthetics or eye shields or NSAIDs. That actually doesn't help the healing go significantly faster. You don't want to put an eye patch on, a compressive eye patch. An eye shield is better because you don't want to push against the cornea that's already been damaged. You certainly do want to follow them up closely. And again, antibiotics, a lot of people do use topical antibiotics, ocular antibiotics, but again, whether or not that helps with healing is an area of debate. If the foreign body is embedded in the stroma, or it appears to be intraorbital, or again, if they have a positive Seidel sign, you want to refer them right away. Contact lens use, you want to stop that until there's been full healing of the cornea. You want to make sure that they're followed up regularly until they're healed. And again, topical antibiotics could be used, but there's some debate to that. There's no strong evidence for topical NSAIDs, cycloplegics, anesthetics, or eye patching. And again, not talking about patching as much as shielding, because you don't want to put pressure right on that. And as I said, you want to refer the open globe injuries right away. If we get back to the blunt trauma situation, you do want to confirm the absence of other injuries, and then really it's supportive care. Cold compresses to reduce the swelling, but again, you don't want to put direct pressure over the globe itself. For hyphemas, it's a collection of blood in the anterior chamber. You classify it by the amount of blood in the chamber. And you can see the grades there with a full top to bottom filling of the chamber being grade 4. You want to check the pupillary light response. If they have no pupillary response to direct light, but consensual response is maintained, that does suggest an optic nerve injury or retinal damage. and that may be due to more than just the hyphema, but the hyphema alone could do that as well. If you're going to measure pressure on the eye, you want to avoid this for a while because rebleed can occur, although acute glaucoma can occur as well. And so we suggest that this is done by an ophthalmologist. And the treatment goals are really prevention. You want to prevent rebleeding, you want to prevent corneal staining, and you want to prevent glaucoma. And so that's the importance of the treatment, is to prevent those things from occurring. Certainly, mild cases could be treated with observation alone, while severe cases may require hospitalization. I tend to not like seeing hyphemas, and I tend to like having ophthalmologists see hyphemas. So if I have one, I'll often send these athletes to an ophthalmologist as quickly as I can for their more definitive care. The treatment is to rest in an inclined position, so the blood layers out in the inferior portion of the anterior chamber and doesn't stain a greater area of the cornea if staining is going to take place. Eye patching or shielding, sedation to minimize activity and the likelihood of recurrent bleeding, mydriatic eye drops, and again, an ophthalmology consultation is highly recommended. Sometimes the ophthalmologist has to actually evacuate the blood if the pressures are high, or if it's a slowly resolving lesion. But again, I would save pressure testing for the ophthalmologist as well, because just by testing the pressure, you could increase the risk of greater bleeding. Basketball player is elbowed in the eye and presents with eye pain, blurred vision, and double vision with numbness on the cheek. What I want you to think about here is orbital fractures. If you look at facial fractures in the general population, orbital fractures make up approximately 25%, 24.7%, according to this particular study. And I'm sorry I didn't, oh, it is there down there, the Annals of Plastic Surgery back in 2008. If you look at facial fractures that take place in sports, you can see that orbital fractures make up just over 25% of the fractures. So it's fairly common. If you look at the anatomy, this is a Netter drawing showing the orbit moving clockwise from 12 o'clock. You have the frontal bone getting over into the 3 o'clock region. You have the ethmoid, lacrimal bone, and palatine bone. Then as you get down more to the 6 o'clock position, you have the orbital surface of the maxilla. And then getting out into 7 o'clock, 9 o'clock, you have the greater wing of the sphenoid bone and the zygomatic bone creating your orbit. When you see somebody, you want to rule out emergent eye injuries, globe injuries, hyphemas, things of that nature. There are other things to rule out as well, concussions and things of that nature too. And so you're going to look for things like significant swelling, ecchymosis, enophthalmos, where the eye appears sunken in. Again, these things are going to be suggesting an orbital fracture, inferior orbit fracture. Palpable defect in the inferior orbit, periorbital emphysema, which is air, so you get this kind of bubble wrap kind of feel to the structure below the eye. A limited upward gaze as the inferior rectus muscle is trapped, and then cheek numbness if you have infraorbital nerve injury. CT scan is probably your best diagnostic test to find this out. Here's a CT, a coronal image, where on the right side you can see that the inferior rim of the orbit does not go all the way through, and you can see the fat in the inferior rectus muscle herniating through. I tried to go back about 2 weeks ago. I had a 14-year-old in the office who came for a concussion evaluation, and he actually had an orbital blowout fracture and trapped fat, so we had to send him off to get that taken care of. So I apologize I didn't have my own case here to show you, but this is a nice representative CT scan that shows the inferior orbit blowout. You have to have a low threshold for referral. Certainly if there's concern of a globe injury, loss of visual acuity, leaking humor, the sidal sign, impaired extraocular movement, or enophthalmos, those are reasons for urgent or emergent referral to ophthalmology. If there's no evidence of severe eye injury, icing, resting, over-the-counter analgesics, and keeping the intracranial pressure low, avoidance of nose blowing, coughing, open mouth sneezing, Valsalva, and things like that are helpful in supporting the recovery. see, we got about 7 minutes here. So 19-year-old athlete, again, takes a blow to the eye at a basketball game. They're bleeding. So lid lacerations are common. You see a lot in basketball. You do want to confirm the absence of other injuries. We've talked about those other injuries before. When you consider the soft tissues of the eye, you do want to remember that in the superolateral aspect of the lid, you have the lacrimal gland. On the medial and inframedial aspect of the eye, you do have the collecting system, and lacerations in those areas can affect the gland and the collecting system. So you want to be extremely cautious if that's where the lacerations are present, and potentially hold off on treating those in a training room setting. Most of the lacerations are going to be because the elbow hits the athlete at the orbital rim, and so it's going to be in the brow, eyebrow, or maybe a little bit above that, and not actually in the lid itself. If you're going to repair the lid using local with lidocaine with epi, unless the epi is otherwise contraindicated, is a good thing to do. You can consider doing blocks as opposed to doing local injection of anesthetic, because the local injection of the anesthetic can blow up the tissues and kind of distort the tissues for you, and make it a little bit more difficult to tell how you should do your closure. You do want to use a non-absorbable suture because it's less inflammatory, and you get better cosmetic outcomes, and the skinnier the thread, the better the outcome. You want to use interrupted sutures and remove them around 5 days. Adhesives are not recommended around the eye. You don't want to glue the person's eye shut. You want to consider tetanus prophylaxis in patients who've had a laceration. And if you're going to use topical antibiotic ointments, try to avoid triple antibiotic ointments. There's about a 10 to 15% chance of neomycin allergy and an inflammatory reaction to that, which can actually lead to a less desirable cosmetic outcome. Talked about blocks. This is just a drawing to remind you where the nerves are around the lid and where blocks can be performed. If you're dumb enough in your own office to get cut on your eye, as I was one day, and you don't have anybody else who can sew up the laceration, you might have to sew up your own. I could not use anesthetic, because if I used anesthetic, the anesthetic would drop down into my eye, and therefore I didn't know if that would alter my ability to see what I was doing. So yes, that is me sewing up my own brow laceration in my office. We have about 5 minutes left. We can probably push through one more topic. Does someone have one more topic they want to talk about?
Nose.
Nose. Let's hit it. That's his ear again. What the heck is that all about? I thought I hit nose. Let's go back one. Do that. Maybe I have it on the wrong thing. I do have it on the wrong thing. We'll get there. Hold on a second here. I'll get there for you. All right, here we go. Sorry about that. So, athlete gets struck in the face by a softball. Complains of facial pain and nosebleed with no visual changes and no frank concussion symptoms. Epistaxis and nasal bone fractures are very common, especially with blunt trauma. And so let's talk about those. Kieselbach's plexus in the anterior aspect of the nose is the area where most bleeds occur, and most bleeds are anterior. This is a common board question for you as well. The bleeding can be quite profuse and difficult to control. I don't know if any of you have worked ERs where you had someone come with a nosebleed and it just seemed like it would not stop bleeding regardless of what you tried to do. And so it's very common that this will take place. And again, if you're there during a practice or certainly at a game, you will encounter nosebleeds. You do want to check their vital signs, make sure that their airway is patent, that they're not draining back into their throat and having difficulty with their airway. You do want to assess for additional injuries such as concussion, eye injury, nasal bone fracture, and so on. And again, try your best to identify the location of the bleed. The first thing that I do with patients who have a nosebleed is I have them blow their nose real hard. I want them to blow the clots out so we can get a good look and see what we're dealing with. And then compressive therapy is a good place to start. They can do it with their own nasal pinch. You can see it within the person on the left, they're pinching in the anterior aspect of the nose where Kieselbach's plexus is. You can design little compressive devices with tongue depressors and tape, as you see there. That you can use a chip clip if you want. If you happen to have one of those in your bag and you carry one for nosebleeds, it's a good way to go. But you want to hold that compression for 10 to 15 minutes straight with the head pointed forward. You don't want them to be draining backwards and choking on their blood. And so all the old wives' tales about leaning your head back and pinching your nose, you actually want to lean forward because you don't want to swallow your own blood as things are going on. If you're having difficulty getting the bleeding to stop, you can use silver nitrate sticks. You can pack the nose. The nose will take a lot of packing, so don't be shocked as you're layering in gauze as to how much packing can go into that area. A nasal tampon, a rhino rocket, nasal balloons, those kinds of things can create pressure in there and tamponade the bleeding as well. So those are things that can be used if the bleeding is more difficult to control. Nasal bone fractures, when you talk about facial fractures, I showed you this slide earlier, the one that's coming up next. Nasal bone fractures are actually the most common facial fracture in high school sports. And while orbital blowout fractures are not unusual, orbital rim fractures, superior rim fractures are fairly uncommon. If we go back to the study that we were talked about before, and we look at the nasal bone fractures, which we'll highlight here, of the total facial fractures, all comers, it only makes up about 17.7%. But when you look at sports, it actually makes up nearly 40% of facial fractures in sport. Now, when you look at individual sports, this was a study that came out in 2010, and I've not seen that it's been duplicated. Nasal bone fractures make up about 7.2% of all fractures in sport. But the interesting thing to me about this study was that when you look at basketball, both boys and girls basketball, nasal bone fractures make up just under 20% of all fractures in basketball. And again, this was high school sports. When you look at softball, it was 1 in 4 to 1 in 5 fractures were nasal bone fractures. So again, in certain sports, there's a very high incidence of nasal bone fracture. The history is what you would expect: direct blow to the face or nose, facial nasal pain. Epistaxis may or may not be present. It doesn't have to be present in the picture of a nasal bone fracture. Difficulty breathing may or may not be present. It depends on how much blood is clogging the area, whether a septal hematoma is forming, things of that nature. You want to look for obvious nasal deformity. You want to look for a septal hematoma because that can lead to significant complications. You want to check their dental occlusion because they could have a maxillary fracture, and you don't want to miss that, certainly. So you want to make sure that their teeth fit right, if you will. You want to palpate all the facial bones, nasal orbit and maxilla and mandible. So a person may come in with an obvious deformity of the nose. You want to check to make sure the extraocular muscles are intact and their visual acuity is good, because again, you do have to rule out other types of injuries such as eye injuries, concussions, and potential C-spine injuries. X-rays can be done. X-rays are often disappointing, I find, when you're looking for nasal bone fractures, and I get a lot of disagreement with my radiologist where I think I see something, they say they don't. The patient is just horribly tender and you feel crepitus in there, you know they've got a fracture. But again, it's often missed on plain X-rays. CT scan is certainly more sensitive and specific, although there's a lot of research going into the use of high resolution ultrasound as an alternative to look for nasal bone fracture, and it is showing promise. And this is just to show the specific numbers on accuracy, sensitivity, specificity, and such when it comes to the use of CT scan. So your goals of treatment is control control pain, control swelling, control epistaxis. You want to help them maintain their airway. Again, leaning forward is a good way to do this. You want to protect them from further injury. So maybe the use of a mask if they're going to return to play, depending on the sport. And then realignment of the nasal bones can be undertaken. This is not something I would do in the training room. Usually I'm going to send them to an ENT to have this done. If they're in a high-risk sport, and they don't have a septal hematoma, oftentimes we'll wait till the end of the season, because I had a case once where a kid came in, had a nasal bone fracture. Parents wanted it fixed. We got it fixed. A week and a half later, he broke his nose again, got it fixed. And then 3 weeks later, he broke his nose a third time in the same season. So it was, again, if there are no major complications or major risk factors for complications, it may be good to delay the reduction of the fracture for a short period of time. Now, a septal hematoma can form. It's not common, but it is associated with nasal bone fracture. This is when the central septum has blood collecting on either side of it. It can be one side or the other, but the collection of blood can lead to abscess, or the pressure can lead to destruction of the septum itself. Perforation can occur, so that cartilage necrosis from the pressure can happen, and they can develop what's called a saddle nose deformity, as you see here. And so you want to make sure you're looking for septal hematoma. And if you have one, you want to make sure that you're sending them off for treatment appropriately. I personally do not drain these. It can require incision and drainage with packing, but again, close follow-up to watch for recurrence is important because we don't want to have those complications of the septal necrosis, perforation, and saddle nose deformity. And so I'm looking at my watch. It's a couple minutes after. I apologize for that. There were some topics we did not get to, but in the interest of time, we're gonna call it at that one, I believe.
Jim, thank you very much. That was fantastic. Very detailed, excellent cover of a lot of really common things in the training room. So hopefully we're all feeling a little happier about some of that stuff going into flu and COVID season. Some reminders, if people have a fever, they should not be participating in sport. I think Jim said that 2 or 3 times. It's a common board question. Jim, one last question. Do you ever use the neck check where symptoms above the neck or below the neck help you decide if people can return to play?
Yeah, I do like that. We talked a little bit about that when we're talking about upper respiratory infections, things from the neck up versus the neck down. Neck down always bothers me more. It tends to be more problematic for the athlete with regards to their ability to perform, whether it's in practice or in a game situation, at their best. And I don't want to prolong their troubles by trying to force them through activities when their body's really just not ready for it either. So above the neck, I'm not as worried when it comes to respiratory infection below the neck, systemic things, including GI upset and fever. That's going to be something that I look at as well. So yeah, I do like that.
Last couple of comments would be on CT scans. You mentioned that quite often for facial fractures. There is a difference between the typical head CT scans that you get in the ER, which sometimes also include the face, whereas you need a high-res CT really to actually pick up fractures. So beware of a negative CT scan in an emergency room, because that doesn't necessarily exclude fractures. And like Jim had said there, sometimes you're arguing with the radiologist about what the studies show based on your clinical impression. And then my last question would be just about the use of nasal tampons. I've found that is quite effective to treat epistaxis immediately, and actually probably sometimes kind of fixes that malalignment of the nose in the acute setting. Because that those athletes, if they go to the emergency room, nothing is going to be done. They're just going to sit there for hours, and they're going to follow up with ENT to evaluate them at a later date. So I think you do have an opportunity to realign if you're using a nasal tampon for epistaxis. But aside from that, I don't very often, if ever, realign noses myself.
Yeah, the longer you wait, and this is true with a lot of fractures, the longer you wait, the stickier, if you will, the fragments become, and the harder it is to get them back in position easily. Yeah. And so, like you said, that's where putting some type of tamponade device in there that takes up space, it's going to create kind of a midline shift, if you will, potentially as well. And that can, like you said, that can realign quite nicely. And for some athletes, it's a badge of courage to have changes in from their fractured noses. So sometimes you even have to talk people into getting them fixed, depending on the sport. It's like cauliflower ears, which we did not get to. For certain athletes, they're excited that their ears look beat up. It means that they've been competitive for a long time at a high level. So
Yeah.
sometimes you have to protect the athletes from themselves when they're making some of these decisions on treatment.
We have one last question posted here from Joseph saying, many colleges have campus health centres and athletes seek care for URIs, COVID, flu, etc. Do you prefer athletes to see you in the training room for all these issues, or do you sometimes recommend seeking care like at an urgent care or campus health centre?
We in our particular environment, the campus health center and the medical record system that we use, it's all part of the same hospital system. So we would have access to the records that are being put in regarding the patient care. We like to be in charge of our athletes' care. It's not a control issue as much as it is a knowledge is power kind of issue, meaning if we know what's going on, we feel that we can help them more. It's not the power of controlling them, but it's the power of knowing what's going on, so we are up to date with everything that's happening. Now, that being said, we are not, we don't have OSHA certification in the training room to perform certain tests. And so there are times when we have someone who needs a test, we will order the test. We don't draw blood there. We don't do rapid streps. Where we will order the tests and send them to student health to have those tests performed. But that fast tracks them straight to the lab as opposed to having to be seen by one of the urgent care providers in that setting. But we like to treat them ourselves. Now, as I said, I don't like to bring sick people into the training room. It doesn't mean that we're not providing their care or directing their care.
Good. I think that's an excellent place to end. Jim, thank you very much. That's been a great session this evening. I'm sure everyone on the call agrees.
Hamish, it was great to see you. Thank you, everybody, for joining us. Appreciate it.